Hi, I am Dr. Prasad Narayanan. I am the Senior Consultant and Director of Medical Oncology, Hematology and Stem Cell Therapy at Cytecare Cancer Hospital in Bangalore. So when we talk about traditional cancer treatments, be it chemotherapy or radiation therapy, we are actually looking at a situation where we are trying to kill the tumor cells. And when we associate cancer therapies, we always think that there is a suppression of immunity which happens. So what is new about CAR T cell therapy? This is a new form of treatment where we are trying to use the patient's own immune system to fight cancer. So how is it done? So the T cells are the cells in the body which actually fight against, give us immunity, and they also try to fight against cancer. So this is an empowerment of T cells. We can say that CAR T cell therapy is like a live drug. So you take the patient's T cells, you genetically engineer them in a lab, and then we attach certain receptors on the surface of these cells so that these cells are now enabled. When you give it back to the patient, they have a mechanism by which they can go and kill the cancer cells. So this is a very novel form of treatment. The research has been happening for maybe 2 decades, and now we have meaningful treatments which have come in CAR T cell therapy. So traditional cancer treatments we all know, which included chemotherapy, radiation, and the focus was to give higher doses of therapy to get maximum cell kill and cure the diseases. And this achieves, there is a threshold to which we can achieve this in our life, because we are not able to cure all the cancers as we know. So there has been an attempt in different forms to tweak the immunity, and this has been done in different forms. Allogeneic stem cell transplant being one of them, where we were trying to give a graft to the patient and try to balance this out, like give chemotherapy with high dose, give a graft and try to get an immune response. So when we talk about CAR T cell therapy, which is a novel form of treatment in cancer, this has actually worked in situations where even an allogeneic transplant has failed. How does this work? So here we actually take the patient's own T cells and then we genetically engineer them, and we make the T cells express a receptor. This is known as the chimeric antigen receptor, which makes them, and when you give it back to the patient, there is maximum cell kill which happens. And this also enables a continuous cell kill, which is what we always want to achieve when we say in technical terms the graft versus leukemia effect and the graft versus host disease, to strike the balance. And this has been achieved maximally with CAR T cell therapy in such a way that now we have 6 approved CAR T cell therapies. We have approved CAR T cell therapy in India as well. So any treatment the most important thing which we consider when we know about the efficacy is the safety. So is it a very safe treatment, the CAR T cell therapy? With the data that we have now, definitely it's a safe treatment, but in expert hands actually. Why is it so? Because when we talk about the reinfusion of the CAR T cells, the most important thing is that we cannot say that the immune system has to respond in a particular manner. So there can be cytokine release syndrome. We all know when the COVID pandemic happened, there was a percentage of the people who became extremely sick because of this. So CAR T cell therapy, the most important side effect, most common side effect, and the most reported side effect is the cytokine release syndrome. So this administration has to be done in a very controlled atmosphere. Most of the hospitals presently are doing it in a bone marrow transplant facility where HEPA filtration is there, and tocilizumab is actually kept near the patient's bedside. So the most important side effect to be discussed is the cytokine storm, which can be managed, and it is not life-threatening in most of the situations. Other side effects which are usual side effects of any immune therapy, like there can be T cell depletion, there can be infections, there can be blood counts which can be low for a particular period of time. But as hemato-oncologists, we are used to managing these side effects. So this is the era of precision medicine. We no longer follow the one-size-fits-all in any cancer, and hemato-oncology is not an exception. So when I say that, what I mean is that we used to give blanket therapy for different diseases for a long time. That has completely changed. This includes treatment of lymphomas, leukemias, multiple myeloma, or any other hemato-oncological malignancy if you take it. So how does it apply, and what are the protocols that have made a difference here? We will take a prototype like a acute myeloid leukemia. So in my acute myeloid leukemia used to be treated with the same treatment for all different subtypes. Now when a patient comes with acute myeloid leukemia, the first thing that happens is that we have to do a flow cytometric test to find out what type of acute myeloid leukemia it is. Then there is something called as cytogenetics to find out a different kind of cytogenetic abnormality which can be targeted with a specific drug particular to that type of acute myeloid leukemia. This is about diagnosis and prognosis. Then what we do, when we give the treatment, we can monitor this abnormality or in a quantitative manner to see whether the value is decreasing with treatment. So we reach a situation where we call it minimal residual disease or MRD. So this is a prognostic evaluation. After that, during follow-up of a patient, initially the only way was to see whether the blood counts are increasing. That was a very crude way of analyzing. But now when you reach a minimal residual disease, for the follow-up of the patients, we can use the same test and monitor it on regular intervals and see whether the MRD is lost. So the MRD, the minimal residual disease status, would be lost 6 months or even 1 year before the patient gets a full-blown relapse. So we can identify recurrences also early and treat accordingly. That is one example. Another example we can say is about chronic myeloid leukemia. Maybe 2 decades back, the only treatment was to do a transplant. Now, no patient of chronic myeloid leukemia gets a transplant. There are at least 4 tablet-based therapy which makes the patient live for decades together. So it has almost become like treating a diabetes or hypertension with a tablet. So these are different kinds of precision medicine approaches in hematolymphoid malignancies.